We should probably get started, although I know that people are strolling in and picking up lunch and everything. So let's get started. It's a very happy day for me because Dr. Bruce Rollman is our today's speaker. And Dr. Rollman is the UPMC Endowed Chair in General Internal Medicine and Professor of Medicine and Psychiatry and Biomedical Informatics and Clinical and Translational Science at University of Pittsburgh School of Medicine. He completed his medical school from Jefferson and also his residency at University of Maryland and fellowship in General Internal Medicine from Johns Hopkins University. He's founder of the Center for Behavioral Health, Media, and Technology at UPMC. He has published a lot. He also has been continuously funded for last 31 years as an NIH investigator, primarily in the relationship between cardiac conditions and depression and anxiety, but also primary care integration and effective treatment of depression, anxiety in the primary care setting, and he'll talk about that as well. He really pioneered the use of EMR alerts to identify also patients for enrollment into clinical trials and published many papers, including in New England Journal of Medicine, in JAMA, and etc. And personally, Bruce was one of my over the years has been my advisor, mentor. He was a consultant for my first auto one as well. And over the years, I really benefited from a lot of his advice. And it's great to see him. He braved the weather and came all the way from Fort Lauderdale, where he was with his wife, and came to Rochester in this kind of weather. And you can only imagine how happy I am to host him. Yesterday we had dinner with a lot of faculty members in my house. And today he'll give a talk titled Online Treatment for Mood and Anxiety Disorder in Primary Care, clinically effective and financially feasible. So please welcome Bruce Rollman.
Thank you, Ben, for the very generous introduction. Ben and I have known each other over 25 years, and I've followed his career as much as he's followed mine. And I wanted to say thank you for inviting me here to be in Rochester. Any time of the year is a good time to be in Rochester. It's cold in Pittsburgh as well. And I looked at the temperature differential. It's very, very similar. So my research work, and this is how I got to meet Ben many years ago, has been on heart disease and depression, and looking at the impact of treating depression in patients with cardiovascular disease. But I asked Ben, what would he like to hear about today? What does he think the group would hear about? Second line of my research has been on collaborative care in primary care. And I'll show you our presentation today is on using online treatment or digital therapies to treat depression and anxiety in primary care. I want to show a work that we did that led to a paper published a few years ago in JAMA Psychiatry, as well as newer work we're doing to try to deliver this in a financially sustainable way using billing codes, et cetera, and not with the benefit of having a large NIH grant. I have no disclosures to disclose. All of the work that I'm going to show you all today has been supported mostly through National Institute of Mental Health. And our goals, as I mentioned before, is to present our NIMH-funded trial of online collaborative care to treat anxiety and depression in primary care. I also want to introduce this model that we have called the 4E model of needed to speed digital health into routine care settings. That involves evidence, eminence, electronic health records, and economics. And in doing so, describe the financial feasibility of using collaborative care approach to provide FDA-approved digital therapeutics and routine care. And then also finally to close with some thoughts about current and near future developments in digital health and steps needed to advance the scientific field. If people need to leave earlier, I'm not offended, not a problem. I'll also be speaking at 1 o'clock on a presentation on creativity with the fellows. So primary care physicians, as people in this audience know, often encounter patients with depression and anxiety. And unfortunately, recognition of these conditions is low, and treatment is often inadequate even when recognized. And it's difficult to get our patients into care with people like yourselves. I became familiar. I don't know if this is like a skip thing, but I became familiar. Let me see. Okay. I became familiar with collaborative care model after my first R01 in the mid-1990s, where we were doing a trial to screen for depression in primary care and then present the evidence to patients, to doctors, primary care doctors, using the electronic health record, either with treatment advice or asking doctors to go to a website that we developed or a doctor's usual care. And at the end of the study, we found there was absolutely no benefit to screening and feedback, which was kind of consistent with other studies done. We were trying to do it a little bit differently using the electronic health record. And I thought to myself, this didn't work. Why didn't it work? And around that time, I discovered the collaborative care model that was being developed at University of Washington and Group Health Cooperative in Seattle by Ed Wagner. And this collaborative care model has been shown to be effective for treating diabetes, heart failure, hypertension, as well as in depression and in anxiety disorders. So, and basically it's using care managers in a proactive approach who reach out to patients. They don't wait for the patients to come in. We track patients using registries and algorithms, for how to adjust care, whether it's anticoagulation, diabetes care, or antidepressant care, with specialty backup. And this model has been shown to be effective in, as I mentioned, in a whole variety of conditions. For depression, there've probably been I don't know if this is like a delay. There's probably been about 80 trials of collaborative care for treating depression in primary care, mostly conducted in the United States. They have an effect size improvement of 0.3, which is considered a small to medium effect size improvement. But these models have been shown to speed access to mental health care, particularly in primary care. But unfortunately, they're still not widely deployed across the United States. So our team has conducted, as I mentioned, I guess I don't know if it's possible to remove the captions at the bottom. Thank you. Oh, that's great.
I didn't know I could do that.
I learn something new every day. So our team has conducted 5 and all NIH-funded trials of collaborative care. The first were in the for anxiety, where it was panic and generalized anxiety, treating over the phone. Oops. The next was our bypassing the blues trial that I mentioned earlier, which was the first trial to apply the collaborative care model for treating depression in a cardiac population. The next was our trial called RELAX, or Reduce Limitations from Anxiety, which used these best practice alerts Ben had mentioned briefly, and I'll show you, to identify patients for treatment. Our Hopeful Heart trial, that's our most recently completed trial, which was a blended collaborative care for treating both depression and heart failure together in a single care by a single nurse care manager, and comparing that to collaborative care for heart failure alone and to doctor's usual care. And then the trial that I'll talk about today, and mostly, is the online treatment trial. So in all of these studies, what they have in common was a care manager. In our primary care studies, the care managers were college graduates, generally in their mid-20s, who called patients up repeatedly and to check how they were doing, administer the PHQ or the GADs or so on, make treatment recommendations after a weekly case review meetings, and then send recommendations back to the primary care physician using Epic. These are the weekly case reviews. I'll show you some of the registry screens. We focused on the newly randomized patients, the patients who are most symptomatic, and those who are completing the intervention. The treatments are pretty well known to people in this group, but it wasn't just throwing people on medications, as I'll show you. We also recommended exercise, sleep, socialization, avoiding alcohol, and basically pro-social activities. And if we couldn't get people to get better, or if there was other kind of complicating things, we freely made recommendations to see a mental health provider in the community. This is a screenshot from our Bypassing the Blues trial of what our intervention case review registry looked like. We developed this, and this is for one patient, and you could see over here, these were all sortable fields by date. You could see how they were doing, and then we would decide whether to tap on the other screens to see their medications or PHQ items, et cetera, see how they were, see how they were doing. In the interest of not belaboring the bypass trial, this was the main outcomes where we showed this collaborative care for post-CABG depression, sped recovery from depression. And at the bottom, we had a third line in there was a non-depressed comparison cohort. So we could see this. We could see this in quality of life scores too. So you could see also the intervention worked on health-related quality of life. But even with treating depression, we couldn't get people to the level of the non-depressed comparison cohort. These were people who also had bypass surgery that we recruited in the hospital and followed up as outpatients. This is one of my favorite quotes from Louis Pasteur about chance favoring the prepared mind. So in 2006, 2007, I took my family on sabbatical at King's College, and I was at the Institute of Psychiatry. And I wanted to learn about the English healthcare system and to pick up some ideas to bring back to the United States. And one of the things that I learned about was computerized cognitive behavioral therapy. And when I was there earlier in 2006, the NHS had come out with a report showing that computerized cognitive behavioral therapy, or CCBT, there was now enough evidence to show that these were effective and cost effective. And so now the NHS would pay for patients to use computerized therapy. So people here are familiar with CBT. I'm not going to belabor the points, but computerized CBT I thought was really cool. Like nobody back in the United States in Pittsburgh that I knew of was using this or testing this. And I thought it had a lot of potential advantages compared to traditional face-to-face CBT. So computerized CBT could be done at home. It was available 24/7. Although the initial programs were done, people had to go to their GP's office in London or wherever else to complete the program. It was reproducible, and there was less stigma than having to see a therapist. And most importantly, there was a similar strong effect size improvement. So these are a couple of meta-analyses, and you can see the collaborative care effect size, and then CBT effect sizes, and then computerized CBT. Supported means having a care manager promoting usage. So you can see the effect size improvements were a lot better than just collaborative care that I was familiar with. In our earlier trials, we were using workbooks developed by David Barlow and also Wayne Caton. We were mailing these to our patients, and our care managers over the phone were encouraging them to do the workbooks and to do the homework in the workbooks. But we digitally recorded the calls, our care manager calls with the patients, both to prevent research misconduct and in case there was a suicidal patient we had on the line, but also like for quality. And my project coordinator and I would listen to some of the recordings, and we would ask the patients, or our care managers would ask the patients, did they have any questions about the workbook, and did they understand, chapter 3 or whatever? But it was a little bit like talking to your teenage kids around the table at dinner, like, what did you learn in school today? Whatever, what kind of homework you have and how you doing. So we really didn't know if patients did the homework. And another advantage to this computerized CBT is that we knew when our care managers logged into the program, we could see what lessons they were working on, if they had done their homework, when they last logged in, and what are the problems that they were working on. So about 10 years ago, there was an article in the New York Times by Tina Rosenberg about computerized CBT. And I was one of the people cited in here, but there was like no studies going on. We were doing like the only study. There was one at Michigan being done, but nobody was doing this in the United States. But these programs were widely used, like in Australia. Mood Gym, the article mentions, had been used 250,000 times. There were programs I mentioned, Beating the Blues and others in the UK, the Netherlands, Germany. They all had, localized versions of computerized CBT in their own languages. But in the United States, almost no one heard of these. So the other thing that we were looking at too when I was developing this application was the idea of internet support groups. So there had been some internet support groups. I've seen also these articles in the New York Times about social networks and the importance of connecting. There was a bunch of stuff going on. I read this article in New York Times Magazine a while ago about Patients Like Me, which at the time was the largest internet support group. It was founded by a guy whose brother developed Lou Gehrig's disease and was looking for help for his brother. And then Patients Like Me really took off, 80,000, 100,000, 200, 300,000 users that would kind of self-identify into certain internet support groups. But there were other ones. You can see here, this D-Life is for diabetes, MyLVAD. There were just so many out there, and there was a lot of face validity where people were saying, oh, this support group really saved my life. I heard e-patient Dave speak once. You can see here, he's got like 500,000 views on his TED Talk from a couple of years ago. And this is a fellow who had a metastatic renal cell cancer. And through an internet support group, he learned about treatment at the NIH and he recovered and now has gone on to give talks at medical meetings. But suppose e-patient Dave had received the wrong treatment or received the right treatment and died. So there's no guarantee. But what I was seeing is that there was also no randomized trials of internet support groups. So, they have a lot of advantages where members with similar conditions, especially if you live in a rural area or have a rare disease, they can connect. And there were some anecdotal reports published that people who used internet support groups felt less distress and social isolation. But at the time, there were no randomized trials to demonstrate benefit. So that's where our online treatment trial came in. So it sounds easy. I started writing this grant in 2007 when I came back from the UK, and we had 2 submissions, and then I put that were not scored, or they were like 25th, 27th percentile. I put the project down for about 2 years, resubmitted again 2 years later as a new project, and that next submission also was like 25th percentile. And then suddenly in June 2011, we got a first percentile score. Now, basically, the 4 grants were similar, but the zeitgeist had changed. And maybe people on the NIH study section had heard of computerized CBT and internet support groups, but it was basically the same project. And we were funded in 2012, and then we were off. But it took about 5 years to get any funding for the project. So there's a lesson there in terms of persistence. If you go to the website, ottrial.pitt.edu, you'll see our study materials, and we published about a dozen papers or so off the project. So trends in collaborative care, 1.0, I would say, is like the early work done by Wayne Caton and Jürgen Unitzer, Greg Simon, and others. That was face-to-face collaborative care, where patients came into the GP's or primary care doctor's office and met with the care manager and so on. We had been doing telephone delivered, or 2.0, we'll call, all along. So in our 5 trials I mentioned, other than getting consent in the hospital for the 2 cardiac studies, everything else was done over the telephone. And then 3.0 we'll call online. So the specific aims of the online treatment trial was to evaluate the effectiveness of delivering a computerized CBT program and an internet support group embedded within a collaborative care intervention for treating depression and anxiety in primary care. And this was the design. We were up and running at 26 UPMC affiliated primary care practices across Southwest Pennsylvania. Our target was to enroll 700 people in about 2 years. And then they were randomized to 3 groups. One was the computerized CBT group alone, care manager, and so on. And the other was the computerized CBT and the internet support group. That was the add-on. So we had one care manager, two separate care managers, one for each of those intervention groups. And the care manager for the internet support group was also the care manager guiding patients through the CCBT program. And then we had a small usual care group. We knew everything by this time. There'd been, like I said, there were 80 trials of collaborative care. We knew everything is better than usual care. So we didn't want to spend our statistical power sending equal numbers of people to each group. So there was only 100 people in the usual care control arm. So we'd have more power with 300 in each of the active interventions. This is a screenshot of the computerized CBT program. You see Ultrasys is the name of the UK company that developed it, and UPMC at the bottom, later around 2010, 2009, made an equity investment to bring a US version. But they, aside from letting us use the program for free, they didn't provide any funding. The main trial showing effectiveness cited in the NHS report was this one by Judy Proudfoot in Australia. The effect size improvement with beating the blues was 0.62, and it was an early and sustained improvement on mood symptoms. These are screenshots of what the program looked like. Typical CBT, people watch these videos of characters, and then they enter their own problems in a list. And the care manager on the other end could see what they were working on and how their PHQ and GAD scores were. This is our internet support group we developed back in our Pittsburgh. It had a lot of the basic elements of internet support groups, where there were how would you say, discussion boards. There were things people could choose their own avatar. We tried to gamify it a little bit. We put the top comments, recent comments on the side. We had guest moderators, whatever we could get people to log in. Here's a user profile. So this person completed the Beating the Blues program, so they earned a badge on their profile. They posted some questions, so they got the magnifying glass. But you get the general idea. These are the discussion boards. You'd see the comments and whatnot, and everything was searchable too at the top. We also created a smartphone version, so if people were in bed or on the bus or in the bathroom, they could also look at the internet support group, just like you could with Facebook. You didn't have to be on a desktop. But these were some of the things that we did to promote patient engagement. It was a lot of fun. We do all these A/B tests to see what was going on. Would it help if we had what was in this subject line versus that subject line, sending something out at the end of the work week on a Friday versus on Sunday or Monday, the beginning of the work week, and then looking at the open rates and the click-through rates and all sorts of different things. It was a lot of fun as we were doing. Ben also mentioned our group had pioneered these epic best practice alerts, and I mentioned these in my discussions this morning and last night. But basically, UPMC has been using Epic since 1999, and we've had an electronic health record since 1996. And so I noticed in Epic that we get these reminders if our patient was due for a flu shot or a mammogram or a cholesterol test. And so I thought, that's interesting. I wonder if we could program it so that if a patient had depression or anxiety, the doctors would also get an alert. So that's what we did here, and we got this through the IRB in the way that so if a patient was being seen for depression or anxiety on the electronic problem list, this would pop up. And the doctors were free to cancel it out. They didn't have to click on it. But if they clicked on it, it sent our study team a referral. And then someone from our study team got back to the patient within 2 business days. And I'll show you over here for online treatment trial, we had nearly 2,900 best practice alert referrals. We were able to get in touch with most of them, and most of those people consented for the screen, and the consent was done over the phone on a recorded line. And our target was to get 704 people. We actually did 700, and we did 704. So that was great without spending a nickel on research assistants and waiting rooms. It was a very clinically efficient system. We've done these for other projects too, like mentioning, we did a sleep study where we developed a best practice alert that if a doctor was prescribing a sleep hypnotic drug, it would fire. And we've done also another one for screening for alcohol disorders. If a patient had a BAL level greater than 0 in the past 12 months, like from the emergency room. But anyway, they're totally cool and they're scalable. And but let me show you the efficiency. So in the first trial I mentioned, where we hired research assistants to approach people in waiting rooms, only 2.4% of the people approached made it into the trial and were randomized. In the RELAX trial, that was our first anxiety trial, that in the same 4 practices as used in Anxiety 1, a quarter of the patients who were referred to us made it into the trial. That is, they consented, they had at least a PHQ 9 of 10 or above, and so on. And we were able to replicate that in the online treatment trial. The other thing is we had an issue with in Pittsburgh with recruitment of non-whites. So Pittsburgh is a predominantly Caucasian county area, and it's an issue when you're doing NIH-funded work because they want to get at least 25% non-Caucasian. So in the RELAX trial, we did 26% at the same 4 practices, and in an online treatment trial, we did 18. I think because we expanded and we were more in other counties that surrounded, like Westmoreland County and Butler County, and places that surrounded Pittsburgh City that had a lower population. But again, extremely efficient way of recruiting. This is the sociodemographics of our group. They were largely female, middle age. I didn't mention before, we powered our trial on age tertile, 18 to 34, 35 to 59, and 60 to 75, because we thought people would use the internet support group, and the computerized CBT groups interventions differently. So we powered within age group, and that's why the age goes up to, well, I guess it's not showed here, but 75. This is the case review screens that we created. Again, similar to what we showed you before with the bypass study, you could sort these to the last GADS, the last PHQ, and so on, and then dig deeper. This is the engagement with the computerized CBT program. So you could see how many people, of the people who were randomized to one of the 2 arms, how many people, 83% activated the program, and then you can see how many sessions they completed. So this is fairly good. There was 8 sessions to Beating the Blues. This is fairly good. I mean, they still could have been in care management, but just didn't do the program. And then you can see over here the differences at 3 and 6 months. Most of the sessions were completed within 3 months. And you can see also by age group too, there was still high rates of engagement. Online treatment, the internet support group, it's very challenging. I don't know, has anyone in this room created an internet support group? Any experience with? It's very challenging to to build an online community and to maintain it. There's competing demands, as you know, for people's attention and eyeballs. You need logins and return visits, and you need helpful content. You know, not just like if it outrages people, they're going to come back to X or whatever else. And so there's some real issues about that too. There's something a colleague had published a paper called the 1% rule, where basically you see this across social media platforms. 90% of the content comes from 1% of the users. Like if you follow things on, you know, Instagram or whatever is your preferred, you'll see you may have tons of followers or whatever, but relatively few people post. So we looked at this again for our trial, and this is like when we started recruitment. So the vertical bars are how many people were in the internet support group. Remember, we wanted to get 300 people in that group. So we ended with 300 people when we ended recruitment third quarter of 2014. So you can see the size of the community building, yet the number of logins stayed relatively constant, you know, each quarter as the site grew. And then you can see over here about just under half provided a comment, and then a smaller proportion, a 10-15% actively posted. So we looked at this from that participation rule, the 1% rule, and we looked at hours, and we found that our top 1% actually did not do 90%. They did 40% of the postings, which I thought was pretty good. We had a little more of a distribution, but it's really hard to do research when you only have 1% people who are super users. And then you can see over here the top contributors, and then how many people never logged into the site. These are the main outcomes from the trial. So we had significant improvements over usual care in both intervention arms, but adding the internet support group did not find any measurable in intent to treat analyses, did not provide any measurable benefit over the computer CBT program alone. Going back to engagement, which is so key with digital interventions, you can see here the ITT is or intent to treat, which is the most conservative. The promise measure is similar to what we saw with meta-analyses of collaborative care in general, but the more sessions people completed, the stronger there was a dose relationship between the sessions completed and the improvements observed in mood, anxiety, and health and mental health related quality of life. How about the internet support group? I mentioned there was no additional benefit in intent to treat analyses, but when we looked at the within the group that was randomized, we could see some potential benefits, but this is a non-randomized cohort where the people who are top 10% can't really analyze 1%, so we combined the top 10%. There were significant improvements or reductions in anxiety symptoms and mental health related quality of life. This is a breakdown, but you could see by different groups and so on. We looked at it also by race. Charles Jonasent, one of my mentees, had published a paper. We found that PHQ scores were similar by race, which is important and maybe a way of using computerized CBT to reduce racial disparities in mental health care. So our conclusion here, large proportions of depressed and anxious people will engage with online care. Computerized CBT is effective and there are dose effects. Internet support group, I'm still out on that too. There was one other trial that's been published and Kathy Griffiths at the Black Dog Institute in Australia published the only other randomized trial of internet support group. And that was also a negative trial that she did. So Black Dog to me is like tops in the world for digital health. Anyway, Kathy Griffiths, KM are her initials if anyone's interested in that. But collaborative care may be the ideal method to provide computerized CBT. Couple limitations, we only tested one program, which is no longer available. We didn't look at the effects of co-interventions. About 40% of our patients were also on an antidepressant or anxiolytic. And we had a simple internet support group. Now we have modern ones that have chatbots and AIs that might also promote engagement. But what we did, 8-10 years ago was cutting edge for its time. Key point, patient engagement is critical. And that's probably no different than therapy. If you're doing face-to-face therapy, are the patients coming out? Are they logging in or coming to your office? If they don't come in for treatment, they're not going to improve or may not improve. About 10 years ago, my colleague, Simon Gilbody in the UK, published a trial that was picked up by the national press that said that computerized CBT didn't work. And he published in BMJ. He looked at the Beating the Blues program that we also used, and he looked at Mood Gym. So Beating the Blues was a proprietary program, and Mood Gym was free and widely available, as I mentioned, like in Australia. But there was no difference that he found, and that's what the media had picked up. But his engagement was really poor. It was like 1 or 2 sessions of 8. And I showed you our group had like 5.5 sessions, a median completed. So it's really, really important before you conclude that something doesn't work or not. You can't just give people the program and expect that they'll benefit. So the next question I go into is how to implement digital health. And we were talking about Deep Throat and Follow the Money. So this is like from the Watergate. Deep Throat was a fellow by the name of Mark Felt who told Woodward and Bernstein when they were on the trail of Nixon and the Watergate break-in, that follow the money. So that's the next thing. So we mentioned the 4E barriers to adoption of digital behavioral health. And this is a project I'm working on right now at UPMC and in our academic primary care practice. So the 4Es are evidence and eminence, electronic medical records, and economics. So evidence, you want to see randomized trial benefit. Eminence is where you get professional societies, that make guidelines or approve payment like NICE in the UK or FDA. So we're proposing to use FDA-approved digital therapeutics linked to Epic, both to identify people and also to track with the registries and to provide feedback to the primary care physicians. But something that we haven't done before is the economics and try to come up with a financially sustainable business case for delivering collaborative care. This is, again, I mentioned this to Ben last night. So I finished my MBA just in December 2024. I did it at the University of Pittsburgh, a healthcare MBA. And the reason for doing it is because I wanted to look at another approach to implementation science. So I go to these implementation science conferences in DC most years, and it's about 80% PhD and about 20% MD investigators, but there's no one with a business background. And I wonder if that's why they say it takes 17 years for published evidence to get used. Most of us don't have these skills. So I thought if I could understand this and have the credibility, it may be another way, another approach to implementation science about figuring out how can we implement. So I'll share with you this model that we're developing about a financially stable digital first strategy. So first, let's say that, and this is as of about 3 years ago, collaborative care became billable. So I think in New York State, it might have been earlier, but nationally, there are now billing codes for reimbursement for care managers' time to deliver collaborative care. Next, digital therapeutics began to be covered in January of 2025. But CMS has said that it has to be physician prescribed and it must be FDA approved. And then there are also G codes to pay for ongoing treatment management services. So this is a paper. John Torres is a colleague of mine at Beth Israel Deaconess. He's a senior author of this paper that had this came out in November. And it was these are the FDA approved digital therapeutic programs. Now, some of them, like Somrest, was from Hair Therapeutics, and that company has gone out of business. But these are the ones that like Sleepio and Daylight and others. These are the ones that are out there right now. So our practice, our academic general internal medicine practice, is 4 office locations. We have a lot of attendings, but relatively few FTEs because the attendings are running the residency program and teaching and medical school teaching and seeing patients, et cetera. But last year, we had 25,000 patients. And of those 25,000 patients, nearly 2,200 were hospitalized or went to the emergency room. And our practice currently has a program where we call patients, a nurse from our practice calls patients within 7 days of discharge, to medicine reconciliation, to make sure people have scheduled follow-up appointments, and to identify early problems that might head off a early readmission. We also have a number of diabetics in our practice, no surprise, but a fair number of them also have an glycosylated hemoglobin above 9, which is a measure of poor control. So our thoughts are, why don't we screen the highest cost patients for depression and anxiety? Because we know that also the prevalence of depression and anxiety are 2 to 3 to 4 times higher in people with chronic medical illnesses, cardiovascular disease, diabetes, kidney disease, et cetera. And at these issues, if you have comorbid depression, it leads to worse control of the underlying disorder, and there's an increased healthcare costs across the board. This is a quote from a UPMC health plan executive, that they see 40% increased costs in medical care if a patient has a depression comorbidity. So this is a general idea. This is for our year 1 plan. So we're proposing a 3-year pilot. And in year 1, we would screen the people who are hospitalized and discharged, because that's already part of our routine care at UPMC in our practice. And then we would also screen, because we have a registries in Epic, we can identify who are our most poorly controlled diabetics. And we have diabetes care managers in our office. And those people would screen people for depression and anxiety with a PHQ-2, PHQ-9, or GAD-2, GAD-7, and then go from there. So here are the care managers. We thought, okay, what's the caseload? In our clinical trials, our caseloads were about like 30 to 40 people, non-digital, but our care manager care managers in our online treatment trial had between 90 and 100 patients as a caseload using the computerized program. So we thought we could have a larger caseload, bring the cost per case down. And then in year two, after we figure all this out, we'll expand screening to inadequately controlled hypertension, people with heart failure, insomnia, chronic pain, et cetera. This is the insurance distribution of our practice. And I'll get to that. It's important because different payers pay different amounts for collaborative care and digital therapeutics. So it's important to kind of like figure out what's the average. So that's what this is, our weighted revenues by billing code. So you can see with the screening units, there's a billing code there's a collaborative care billing codes, but the FDA therapeutic codes 0553 and 0554 to follow up are much less than the collaborative care codes. And it's unclear right now if we could use both, but so we'd probably go with the higher collaborative care codes. 0552 is the cost for acquisition, and that's to be determined by individual insurer. These were the number of calls our care managers made in the online treatment trial I showed you. So it's about a dozen calls, and I'd say probably 2/3 of these were made in the first 3 months. So we're estimating these would be the billing revenues per patient average, depending on everyone gets G2204 and the 99492 in the first month. Half the people need extra time, and then so on and so forth by month. So our practice revenue calculations were these. Our practice expenses are those with the, we tried to be conservative in year 2 and year 3 at a 3% cost of living adjustment, even though we kept our revenues the same. And then we're estimating insurer savings. We looked at trial-derived evidence of cost savings from collaborative care, treating depression in medically ill populations. So the Donahoe 2014 paper was ours. We analyzed Medicare claims, Medicaid, UPMC health plan, and Blue Cross Blue Shield, and we found a nearly negative $2,000 cost savings. But there was a meta-analysis that pegged us at about negative $500. So we used their number to be conservative. And then they also looked at work by Greg Simon and Wayne Caton with the team care and another trial that Greg had done in diabetes. So we tried to be conservative about the savings for the insurer. And then we medication adjusted it to current dollars. So this is a summary. So you can see for net, and there are different stakeholders involved. So the stakeholder of our practice doesn't want to lose money on this. So if everything worked out well, they wouldn't lose money. There'd be a small gain over 3 years. For the insurers, it could be a total loss, but we're estimating and trying to be conservative about it, what they might gain. And then let's say that we get no reimbursement from our practice, and the insurance company picks up all the costs. This would be their savings less expenses for our practice. And this is, let me add also on the bottom, this is exclusive of what's called shared savings. So we're thinking above billing revenues, our practice may get extra payments for doing better care of diabetes, lower rates of hospital readmission, and a improved MER, or medical expense ratio. So a couple of key assumptions. One is that you have to have a stable payer mix. The depression and anxiety screening by our clinic staff is reimbursed. The digital therapeutic programs are reimbursed by all payers and lines of business, and we're not quite there yet. And then also the 12-month time frame. So like the Wayne Caton paper for team care had a 24-month time frame where they found that there's more increased savings in the second year than in the first year. So that's important. And maybe they treat depression and you might have continued savings, and it's kind of conservative to estimate just on 12-month alone. So digital first strategy is a win for what we call the 4P stakeholders. It's a patient win because it speeds access to proven effective care and hopefully improve control of chronic conditions. It's a provider win. So the PCPs in our practice have new options for referral, and they could potentially improve payments to the practice through better control of our patients' chronic conditions. that's the provider. The practice wins for that. And then finally, the payer wins. They would hopefully have lower expenditures due to improved control and gain experience with FDA-approved digital therapeutics. They're not going away, but UPMC, like many, has had some experience, like with Beating the Blues and some other homegrown products. But the engagement rates are extremely low. So let's finish, because we're almost out of time, about some thoughts on the near future. Does anyone know what movie this is from? All right, I'm just wondering. Sometimes my references, like Deep Throat, could be lost. I don't know. So this is a paper we published about where we see precision medicine going to phenotype. So everyone's familiar with genotype and phenotype, and people have used the term digital phenotype, but we like to think of it about phenotype, because your phone knows so much about you. And there are now even programs that will sense your phone. They know if you're up in the middle of the night, what emojis you're using, sentiment analyses of words, how hard you're banging the keys, and so on and so forth. And they know your locations. I mean, how many crimes have been solved by people knowing where someone is located and just tracking them on the cell phone towers? So there's so much information in the phones, and you can see that going into mental health treatments. We're having a conversation this morning with Caroline about what's that called, where they have the digital, where they know where you are with the location, geofencing, because your phone knows where you are. So maybe if you're near where you might buy drugs or some other risky spot, you get a call from your care manager saying, hey, Joe, what are you doing in that neighborhood? So that kind of stuff is there today. Internet support groups, I don't know. I think in the future they could be branded. You could have University of Rochester branded, UPMC branded, Cleveland Clinic, deployed by accountable care organizations that are professionally moderated, organized by condition, and to promote patient retention within the system. But recognizing yet that there's still not like a lot of great data out there on randomized trial, but some people like ePatient Dave might find some useful information. These internet support groups, I also believe, will be connected to the electronic health record, and that's the third E in the 4 E's, where there'll be predictive analytics that'll just like Netflix might say, or Amazon, you watch this movie, you bought this product, you might like this too. So I think that's those kind of things, predictive analytics that anticipate what you're going to need, when you're going to need it. They always talk about JIT interventions, JEDIs, just-in-time interventions. And I think the technology is going to be enabling that over the next couple of years. For digital therapeutics, I think there's going to be improved programs, tailored programs, adaptive designs. Like Beating the Blues, you have to go through sessions 1 through 8 serially. But maybe in the future, there might be adaptive designs where everyone does 1 and then you skip, depending on your conditions, to 3 or to 7 or back to 5, depending on how well you're doing and what's the information contained. I think there'll also be versions that specifically address medical comorbidities. Just like you have Cheerios and you have Honey Nut Cheerios and you have whole wheat Cheerios. There'll be all these different brands, but that's the trend. So maybe there'll be like Beating the Blues for people with chronic kidney disease. I'm involved right now with a colleague at Pitt who's doing computerized CBT for dialysis patients, because they're literally a captive audience sitting on those machines, and they have high rates of morbidity and depression. EMR integration, we talked about digital health readiness. We have a paper recently published on that too, that people are ready to use these, that they not only have the technology, they know how to use the technology. And then finally, augmented intelligence, not artificial intelligence, but augmented intelligence, where you have the phenotypes that sense on your phones and the predictive analytics that make things more engaging. I think that's going to be a lot of the future. Also in the future, I think we need to figure out how to implement this. Is it going to be, what's the model? Are we going to have navigators, care managers, user experience design, behavioral economic techniques like loss aversion, other kind of things, keep that streak going to win a prize? I don't know. But I think the engagement, I know, is going to be really key. So to the extent that we can figure that out at a relatively low cost at scale, I think is going to be important. Tim Bober is a fellow working with me at Pitt. He's now a junior faculty member, and he published a paper on digital health readiness, So it's more than just having a smartphone or internet connection, but do you know how to use the technology? Like I'll see patients when I walk in at their room to see my patients, they're playing Candy Crush or whatever while they're waiting for me, but they don't know how to download an app, or they don't know how to use the My UPMC system to allow a video visit. So, I think it's really important that people, and maybe it's more common in older people. I know my mother-in-law has she has an iPhone, but she doesn't really know how to use it, even like to pick up the phone. So you can't necessarily assume because someone has the technology that they're digital health ready. Is anyone familiar with the hype cycle? So if you Google some kind of technology and hype with the word hype cycle, you'll see this across a broad range of technologies. So generally, there's where we are, where we are right now with AI and data centers are these peak of inflated expectations before we hit the trough of disillusionment. I mean, how many times you hear about things, oh, Facebook was going to be great, it was going to bring the world together and all this kind of stuff. And then, you get that slope of enlightenment before you figure out where something really goes. This is for telemedicine. So they have these kind of like plateaus. This came out a few years ago. But you could see like they try to like figure out where is the plateau? Where is it going to be? Where are the plateau, meaning over here, plateau of productivity? How many years away are you from there? So, but you could type in, again, AI, chatbots, and any of these words, hype cycle, data centers, you'll find a hype cycle for that. So I think it's important to kind of keep that in mind. Like people are investing all this stuff in AI. Maybe people saw yesterday the market went down for AI. Just be careful about that stuff and ask, where is the data to show true benefit? I think there was a hype cycle 10 years ago or so on internet support groups, for example, until we and Dr. Griffiths are showing that, well, maybe it's not so great, or it doesn't really add anything. We still need effectiveness trials, as I mentioned, powered for key subgroups like we did OT for age, stratified by digital health readiness, identifying those most and least likely to benefit, and all sorts of co-treatments, and finally, cost effectiveness analyses. Those are very, very hard to do. The one we published in 2014, we worked on for 5 years, and we needed another grant from a local foundation finish. And the other one that we have under review right now from our heart failure study, it's also about 5 years of effort. And then finally, I'll close with this slide. This is a classic slide I saw at the implementation science conferences in Washington, where you'd really need what's called R3 research. And so this paper is a little old, but you can see at the top, I mean, basically there's a new iPhone that comes out every year. The pace of technology in the corporate world is so much faster than the NIH funded world, where you have something come out, you develop your grant, okay, you submit it, you wait a year or 2 years, if you're lucky, you get funded, you do the project, you finally finish it, analyze it, publish it, it's another year. In the meantime, I mean, we're on like the iPhone 17, I mean, the pace of technology isn't going to slow down, but you have to figure out, and this article talks about when you're doing studies of technologies, is to have certain basic principles, and basic principles being adequate sample size, randomization, blinded assessments of outcomes, and also like your testing principles, not just the technology. So you don't want to be trapped into like doing what is the, how well does the iPhone 17 work for X, Y, and Z? Well, by the time you're published, you'll have the iPhone 24 out, but you want to do the principles of what are you testing? Maybe it's mobile health or maybe something else, rather than the specifics of a particular technology. It's impossible to do randomized trials on every single iteration of something. So again, blinded, adequate sample size, blinded assessments, and objective measures. And that's it. Thank you.
Thank you so much, Dr. Rollman. I mean, on behalf of those of us who live in the trough of disillusionment, I just want to say thank you for a very exciting and informative talk. We have a number of questions online, but I wonder if we have folks in the room who want to get us started. Dr. Gansner.
Hi, thank you for that talk. Oh, over here. Hello. I definitely agree. There's a lot of promise in moving towards technology and digital therapeutics, but I also am a bit of a skeptic in certain respects. I have specifically some skepticism surrounding companies and private companies' investment in getting individuals off the therapeutics, right? Like with apps, the incentive is to continually use the app and to not get people to disengage. But inherently, we want to get our patients to the point where they do disengage and can disengage. And so particularly when you were mentioning tracking people and getting people to the point where we might be giving them tools that they become so reliant on, they no longer are learning coping skills on their own. They're relying for the phone to intervene, right? The app to intervene, the intervention to make the decisions for them. I think we're getting into ethically murky territory. So I'm curious what your thoughts are about that.
So the programs aren't for, it's a good question too, about you want to get people off screens. So they're not for everybody. So like when you look at the programs, like, again, someone has to be ready or willing. Like my mother-in-law would never do this with a computer program if she needed help. So it's not for everybody. I think but for people who are interested, it potentially opens up another, how would you say, access to care. But some people are really complicated too, that it's also not appropriate. Let's say you have impending divorce or job loss or other kind of things, or trauma. These programs may not be appropriate for use, and they should also be used not by just, buying it on your own, going to Lilly Direct or Trump RX or whatever, but you really need somebody who's skilled to oversee their use of these programs. So our care managers would promote people logging in, but they would also see their progress. And if they didn't log in, they would call and make sure they're okay. But we were still also doing traditional collaborative care over the phone and by my UPMC portal messages to make sure that they were okay.
Thank you, Dr. Rollman. I'm going to ask one more question, combining a couple that came in, and it relates to health equity and health disparities as it relates to the computerized CBT interventions. Do you have any suggestions, or is there any data supporting how to enhance non-white utilization of the computerized approaches and how to increase engagement in those among non-white users?
Sure. So it's a great question. So, I point to work done by my mentee, Charles Jonasant. Charles recently moved to Emory. He's an associate professor there, but he had Jonasant CJ, and he had published articles looking at how African Americans, Blacks, use the Beating the Blues program. And he found that there was high rates of engagement, and also, as I showed you in randomized trial data, that they were equally likely to recover as well as whites. So I think, in terms of engagement, the program is not, they had Black characters in the Beating the Blues program. It wasn't exclusively white characters or all women, or they had a mix of men and women. I believe that there was an Indian woman in there too, a Black, and I think the other 4 were white, I believe, or one might have been Hispanic. So you could say like having faces like us, but I think the key thing is the techniques worked. It didn't matter if you were Black or white.
I think it also, points to Dr. Easton's work around customizable avatars and sort of how that
Absolutely.
enhances engagement. Well, I'm cognizant that we are out of time, but on behalf of our department, including many dozens of folks who logged in to hear your talk, thank you so much for being with us. And thank you to all of you in the audience.
Thank you.